If I may just ask each one of you before giving your presentation to share with us the title or position or experience that is most dear to his heart. I can't say her because, as you can see, it's a man world, really. But anyways, you know, from the so many interesting titles that I can see in your bios, if there's one that is dearest to your heart, what would that be? And maybe we'd start with you, Richard Sullivan. What is the dearest title to your heart, and what are you going to be presenting to us today?
So my background is as a cancer doctor. I'm a surgeon, so I'm going to be talking about cancer care in humanitarian settings today, which is a very orphan area.
And no special title? No? Go ahead, the floor is yours.
Yeah, thank you very much indeed for the invitation. Let me see if I can get surgeons and technology. It's always a disaster. So I'm going to talk today a little bit about and very grounded work we're doing around delivering cancer care in humanitarian settings. The issue here is, of course, that cancer constitutes an incredibly complicated set of diseases, all requiring early presentation, accurate diagnosis, and complex multimodality curative or palliative care. And we're really seeing a dramatic increase in the need for cancer care in humanitarian settings, not just in this region, which people traditionally think about, but also indeed in sub-Saharan Africa and non-traditional regions. Most of our standard models of care are developed in high-income settings, and they're simply not fit for purpose. There's a lot of learnings already. There are many emerging and low middle-income countries that have done superb pieces of work in having much more compressed, innovative pathways of care. But the question that comes down to context still rises very heavily. And of course, what we need to make sure is any solutions we come up for, a lot of the countries we're talking about, they have to fit the domestic populations because they're treating both domestic population and refugees. There's an enormous amount. If you're in oncology, there's a vast amount of commissions, series that the Lancet have published. Some of these are germane to what we're talking about today. A lot aren't. They're really just focused in the high-income settings. We've decided over the last 3 years to focus on probably two of the biggest burden diseases, particularly for sub-Saharan Africa, which is cancer of the cervix and breast cancer, and particularly around the One Health solutions. And really, I just want to make the point here that creative solutions are both technology-centric and they are about whole pathways. The greater use for anthropology, for example, in understanding getting women to earlier present is an innovative approach to actually dealing with these issues. And of course, a lot of this is building it through a research focus, so it's actually being ruthless and rigorous about what we do. I'm just going to give you a couple of examples here. One is using virtual reality, and another one, a completely new model and pathway for low-cost technology for breast cancer. So you'll all be very familiar with the Oculus Rift and virtual reality, and I think you're probably going to hear a lot more about augmented reality tomorrow as well. This is an interactive experience in a computer-simulated environment. It is very effective for learning complex procedural tasks. It's used by the airline industry, by military, by all sorts of people. And the reason it does that is because it stimulates various parts of the brain. It allows a much deeper, harder learning. And particularly in surgery, when you think about this, a lot of this we have to learn about is sequencing procedures and instruments. Now, this is not new. VR and AR, augmented reality, is already being used in high-income countries. But the problem is, these VR solutions, by and large, are very, very expensive. And they're designed around the Da Vinci robot, beloved by my urological colleagues, and minimally invasive surgery. And I'm sure we're going to hear more about that today. So the question is, this is a procedure that we have real problems in delivering in sub-Saharan Africa, particularly in refugee camps and the centres, which is a radical abdominal hysterectomy for invasive cervical cancer. So how can you get reasonably trained pelvic gynae surgeons up to this particular level? And what we've essentially done is we've created, and I'm not going to play this through in detail, this is coming out very soon, a totally immersive VR of basically a Zambian operating theatre. No VR sickness, it's absolutely perfectly one-to-one rendered, including all the surgical instruments and exactly what you're seeing around that. So the individual can go into this and go through individual procedural steps with a real surgeon talking in their ear. Does this work? Well, actually, in the development stage, when we've been testing it out on the Zambian surgeons, Ugandans, and the surgeons from DRC, all who are VR naive, actually it does. It improves between sessions 1 and 3. And you can see step 1. These are the different steps of the radical abdominal hysterectomy. You can see improvements, at least in 3 of the domains, after 1 to 3 sessions here. The really tricky bit here is the medial leaf of the broad ligament and the unroofing the ureter. They're really hard. So it can also tell you where the surgeons start to find it really difficult and where they need more practice before going into the real OR. So basically what we've got now, and this is going to be published very soon, is we have a complete off-the-shelf VR environment for this surgical procedure. It costs about, actually, and it's under $1,000 now. What's really expensive is doing the code and the VR that you plug into these machines. But the hardware itself, once you've done it and you've plugged in the code, it's very cheap. So it can be used, these computers are absolutely fine for being used out in relatively hostile environments. One of the things we're doing now is putting it into real early phase clinical trials with telemonitoring. So watch this space to see whether it really does improve things over time. So that's one example. The second example of sort of innovation Humanitarian Cancer Centre for cancer is this problem. It's by and large, this is what we tend to see in refugee camps and most of the domestic populations of breast cancer. It's highly advanced stage 4 fungating tumours. One of the biggest things is how do we innovate away from traditional models and pathways of care? And actually, one of the things we've been doing is new approaches to social anthropology. So people don't think of this as traditional innovation, but it really is. Understanding why it is women are not presenting early enough and embedding that in the pathways of care. So this isn't a technology solution here. This is a pure social anthropology solution to early presentation. The other things we've had to do is we've had to use old kit in newer ways, because one of the things we found is there's no point trying to get women away from the refugee camps or their domestic areas to Lasaka or wherever else. They simply will not travel. So we have to be able to do everything there in the camp. So we've had to come up with new approaches to doing core needle biopsies, new approaches to doing imprint cytology, and this is purely H&E stains, by the way. We're not able to do ER-PR at the moment in the field. I hope eventually to be able to do that. New approaches to actually interpreting the implant cytology specimens. And of course, I love this picture, the on-site data management office. Actually, this really works. It's very cheap, it's highly robust in the heat, and it really can deliver those results. And it allows a central pathologist to have a look at those slides before deciding whether to go ahead. And what we mean by going ahead is actually deciding there and then to operate on the women themselves. And we've had to come up with all sorts of new surgical procedures beyond wide local excision and mastectomy to be able to do this, actually in the field at the same time. So women are actually treated then and there or the next day. Because frankly, after they've left, after their diagnosis, the likelihood is we know there's abandonment is about 50 to 60%. And so basically what we're seeing now is actually a single visit breast algorithm is feasible. You know, people really appreciate it, and particularly in these settings, and we've got 3 different sub-Saharan African settings now we've done this in. You can do same-day surgery even for cancer in selected populations. The issue really comes down with, for instance, radiotherapy. I mean, how on earth do we get mobile radiotherapy into a lot of these camps here, brachytherapy, etc.? And the point I want to make by all of this is it's subject to really rigorous clinical studies and trials, because too much of stuff goes into the clinic at the moment or goes into humanitarian settings, which frankly is fantasy. You know, it really hasn't been subject to the real research that's needed to make sure it's affordable and sustainable and it really delivers equitable care. So thank you very much indeed.
So I think for me what I found quite interesting is your emphasis on the importance of those innovative solutions to be socially appropriate just as much as they are technologically advanced. So unless they are tailored to the needs of the population that they target, they would be not necessarily the most effective. So very much appreciated. Now we move to Pete Masters. You are an MSF fellow. So my assumption is that you will be bringing us back to the very ground floor of where things happen, the reality, the practice. Is that a correct assumption? Absolutely. Floor is yours.
Okay, a quick disclaimer. An MSF perspective, I am one person of 40,000 people working in MSF, so this is actually my perspective as an MSF member of staff on innovative approaches to humanitarian response. And before talking about MSF, I'd like to mention a concept that's been percolating in my brain for the last few months, and it's the concept of the greater fool. And it doesn't sound very complimentary, but I think that innovation generally comes from greater fools, whether they're individuals, teams, or organizations. And it was originally a term coined in the finance sector for someone who goes long on high-risk investments, and most of the time, everybody else makes money, and very occasionally that person gets very rich. But it really clicked with me in terms of innovation when I was watching a TV program called The Newsroom, and a greater fool was described as someone with the perfect blend of self-delusion and ego to think that he or she can succeed where others have failed. And I feel that more and more the humanitarian sector has to be a place where greater fools are nurtured. Okay, that said, when putting this introduction together, I wanted to present some context for innovation in MSF. So I reached out to colleagues who've been around for a long time and asked them what do they think the kind of seminal innovations in MSF's history were. And a few percolated to the top. So I just want to go quickly through them to give you a bit of context. So HIV. In the early 2000s, an MSF head of mission proved conclusively that we could get good outcomes for HIV-positive patients in Myanmar. And this was a real game changer for us as an emergency organisation in the treatment of chronic disease. But to do this, he had to smuggle antiretrovirals into the country, and not only against the wishes of the government, but against the wishes of his MSF bosses. And this, for me, it really epitomises that concept of greater fool. 8 years later, MSF led on the development of the CAGs, the community adherence groups, which proved again that by giving patient groups autonomy over their own treatment and their own treatment supplies, we could provide care to them in rural settings, in unstable settings, and in conflict settings. Again, kind of going against the prevailing wisdom of the time. Rewinding to the 1980s, lots of you won't remember the 1980s, we had the development of medical and logistical kits. So these were beautifully designed based on hard experience and designed to be deployed in the event of specific emergencies. And this was a real paradigm shift in the way we ran logistics, kind of 10xing our ability to respond in those really important early moments of a crisis. And doing what innovation should really do best, which is kind of simplifying and scaling good practice. And this one was a bit of an outlier, I think, hence the picture of Sue and Richard, my parents. In that same decade, MSF took the strategic decision to really focus their fundraising attention on individual giving and away from governments and institutions. And not only did this make us less reliant on governments and institutions, but it also allowed us to respond where we felt the needs to be most acute and at speed. And this decision was high risk, and again kind of shows for me the willingness that MSF has had to really rip up the rule book to make change. So bringing this now to a bit more to the present day and some current case studies I'd like to highlight. So in Amman, Jordan, we have a team that can now provide 3D printed prostheses for war-wounded people from places all around the region for under $100 and fabricatable in less than 24 hours. Really capitalizing on evolving technology to meet a need of today. This one's very close to my heart, the Missing Maps project, which was co-founded by MSF and a consortium of NGOs to draw on the goodwill and the power of tens of thousands of volunteers to provide open geographical data that puts vulnerable communities on the map where previously there were just blank spaces. And what does maps have to do with MSF? Well, spatial epidemiology, good disease surveillance, good quality logistics and supply, they rely on geographical data, and that was just missing beforehand. By the way, if you want to get involved in Missing Maps, go and see the guys from MSF Lebanon downstairs at the stall, because there's a community here. Now, my slides are in the wrong order as well, so bear with me. This is one of my favorites. So this is Labana and his team in Malawi, who are developing a social mapping methodology which enables MSF and local communities to co-create disaster response. So drawing on local knowledge and expertise to really identify high vulnerability and identify where the greatest impact can be had, and also making sure that MSF augments local efforts rather than simply replacing them. This is super cool stuff, I think. And lastly, we have Roger, a logistician who's drawing on lean design principles to redesign decontamination kits that will keep MSF staff kind of safer and less anxious when providing care for people in areas where chemical weapon attacks are a terrible possibility. So none of these ideas are mine. I can't take credit for any of them. All conceived and implemented by people I'm very proud to call colleagues. My job as an innovation advisor is really to try and understand what factors lead to these ideas and to try and amplify those factors in order to, better develop, test, and implement new solutions in the field. So I'd like to share 5 of a potentially very long list of these factors that I think are important, but also some major challenges I think we're now facing if we want to continue to innovate to serve people in crisis. Smooth, right? So number 1, we look our patients in the eyes. Every pill that goes into the hand of a patient is given to them by a member of MSF staff, and 90% of those staff are local staff. This means that our patients' problems are right in front of us, and it's impossible really for us to ignore them. And we also are physically present in the crises in which we're operating. Number 2, we have very hard problems. We operate in places where lots of organizations don't, and where the needs and the constraints are, well, honestly overwhelming, such as in Yemen today. We also try to seek out the most vulnerable, those people that fall through the cracks, and provide care for those with no access to treatment, such as MDR and XDR TB patients. Number 3, I think we have a really fantastic mix of local and international staff. And in my job, I see many people trying to analyze and define what a perfect innovation team looks like. And I always think that our field teams actually map really well onto these models in terms of their interdisciplinarity, in terms of the kind of plethora of experience and expertise and culture that they come from, and in terms of a strong common purpose and values and drive. Number 4, it's a kind of a blend of medical, operational, and technical focus that allows us to draw on technology, both soft and hard, to try and solve problems in the field. So on the left there, you have the adaptation and adoption of telemedicine, which happened across multiple continents in MSF. And on the right, the mobile surgical unit, which is a surgical unit able to move with the front line of a conflict, as recently was the case in Mosul in Iraq. Number 5, which doesn't have a slide, and I think is really important, is risk. The willingness to break the rules, the willingness to take risks, and the willingness to try new things and experiment in order to improve the care we provide and really try and turn things on their head. Just to prove I break the rules, these actually don't align to what I just said, so that's completely wrong again. So lastly, I want to outline what I see as some of the major challenges for MSF in terms of developing this culture of innovation so we maintain ourselves as an organization that's fit to face the medical and operational challenges of what's a really fast-changing world. So in a technological sense, we now work in contexts where connectivity is up there with food and water in terms of people's hierarchy of needs. We hear lots about algorithms and machine learning and AI that offer tantalizing possibilities for developing and scaling care really quickly and on a massive scale. But these things could also very easily threaten our do no harm principles if deployed without huge amounts of care and expertise. The context in which we work and the communities we serve are also changing, and this region, MENA region, is a great example. Here our operations are shaped by sophisticated health systems in decline or collapsing under the strain of conflict or other factors. Across all of the places we work, climate change and population movement and rapid urbanization are already challenging our operational models and will do so more and more in the coming decades. And the nature of humanitarian response is changing as well, as civil society, private companies and other actors are increasingly present in humanitarian response. And MSF is not famous for playing well with others, in case you don't know, but we need to work out how we can fit effectively into these networks and where we can add value and where we can support other initiatives and organizations. And these are big changes for us. So MSF is no longer a young rebel, we're big. We have experienced a period of huge growth over the last few decades. And as is with the danger with any organization experiencing massive growth, with it can very easily come conservatism, risk aversion, hierarchy, bureaucracy, lots of things that counter all the stuff I've kind of laid out for you from the innovations. So I think it's vital that we proactively maintain the space for the greater fools, the risk takers, the autonomy and the flexibility for local teams, and try and bring to bear our experience and capacity to meet the challenges of today and tomorrow. And I have some ideas, but I don't know how we do this. I'd love to talk more about it, both in this panel and over the next couple of days and beyond. But I think it's really important. And I'll leave you with a quote from a guy called Eddie Obeng, who's really worth looking up. And I think it's a bit of a challenge to MSF and the humanitarian sector. We spend our time responding rationally to a world we understand and recognize, but which no longer exists. Thanks.
Hi. I think we need an innovation at some point, someone to create an innovation for the air conditioning. We're freezing since morning. I'm here on AUB faculty, actually at the Faculty of Health Sciences and School of Public Health. I teach management and policy, mostly focusing on policy issues, but also I'm the director of research in the Public Policy Institute, the Sam Faris Institute. I'll be, in a way, trying to, not to challenge the celebration of innovation as we've been seeing since the morning, but probably to critically look at it from the perspective of the communities, as Saba mentioned in the morning, from the perspective of refugees. I want to talk about the challenges that small countries like Lebanon, Jordan, and others, but particularly focusing on Lebanon, face in light of one of the biggest refugee crises probably since World War II. And I will walk you through, perhaps from the research we've been doing in the Institute and in the faculty, on ways that communities themselves, refugees themselves, who are usually neglected from the thinking that we've been saying since morning and by the literature and by the systematic reviews we do, and perhaps look into how innovative they were through the informal mechanisms that they create. This is what I'll try to say in the next 7 or 8 minutes. But I want to put things in context. Currently, there are around 65 million displaced persons in the world. Most of them actually are displaced, including IDPs and refugees. 86% of those refugees in the world are actually in the developing world. So in places where there are a lot of challenges around the economy, the welfare, access to health, access to education. So the crisis is, as a matter of fact, it's not in London. It's not in Europe, it's not in North America, it's actually in the developing world. And this, as a matter of fact, would give us a lot of thinking about how to address innovation in health system, innovation to address crises, innovation in light of these humanitarian crises. And as a matter of fact, I want to give some parallels. Europe has only 2% of its population are refugees and asylum seekers. It's a negligible, number or percentage. Lebanon has around 20 to 25% of its population are refugees. So this begs the question of how those communities and societies have been coping in light of these crises. How populations actually increase 20 to 25%. I'm talking about Lebanon, Jordan, and some parts of Turkey or Greece, and actually they don't collapse, or we don't see real collapse or implosion of these societies and communities, is actually the question that I'd like to address here. And I want to say that part of the response has usually been through the formal response that we're hearing about today, and throughout the day. It's about the international organizations, the NGOs, the MSFs, the small NGOs that operate in these countries, the governments and the ministries, of course, universities. These are all formal ways of response. In places like Lebanon, we've seen more of the non-state response compared to the state, because we're having a lot of issues around the state response, state capacities, state authorities in terms of dealing with the crises. So we saw a lot of intervention taking place by NGOs, international NGOs, including those that are present here in the room. My colleague in Karaguzian will speak perhaps about this in one of the suburbs of Beirut, and so on. So we've seen this. We've seen some innovative, and actually throughout the years, the last 7 years of the crisis, we've seen an improvement in the way the response has become more and more creative and more innovative. In the beginning of the crisis in Lebanon, perhaps in Jordan as well, we've seen just the formal, classical way. We send our teams to those places, and we want to apply the textbook of humanitarian response. But with time, those organizations became more contextualized in their response. So we started to see some innovative approaches, including, I guess, one of the most innovative response that's happening to a humanitarian crisis currently, which is the use of cash. It's not actually only in the health system, it's the use of cash. I see this one of the most innovative and brave ways of actually addressing the support to refugees by creating some kind of an e-card. In Lebanon, we call it Louise, for some reason, maybe an abbreviation, that the UNHCR, the World Food Program, the UNICEF, World Vision, Save the Children, all came together and said, rather than actually go through the classical way of supporting them, let's give them money through this card. And they can actually go and access food, they can access supplies, they can do whatever they want through a certain formula of their need and vulnerability. I think that was one of the most innovative responses through the formal structures of the response. But what we actually have seen along the way of this response, kind of an explosion of technology and other innovative responses or ways that we can resolve the conflict, the need. And one of these, actually, we've seen a lot of these starting in Europe, like tech hubs, refugee hubs, startups, something that we can create and use technology to help them in catering for their shelter needs in Europe and other access to services and so on. We've seen this. But as a matter of fact, I am kind of questioning this because all of these great responses, including the Louise card in Lebanon, including these technologies, tech hubs, including these refugee tech innovations and so on, I don't see them working, to be honest. I don't see them a lot of success in these because, as a matter of fact, they target small-scale interventions. They're not about large-scale interventions where you have 20 or 25% of the population increasing by the displacement. So I want to challenge this in a bit, but I want to say that most of the innovation, as a matter of fact, was happening among the communities themselves. And we've been doing research and understanding how those poor communities, refugee communities and host communities, responded to the crisis. And what we see, those communities have created their own informal adaptive mechanisms. And those are sometimes complex, sometimes simple ways where they actually adapt the current formal responses, formal mechanisms for their own benefit and for their own advantage. We see them, for example, using WhatsApp groups, one of the basic platforms, in order to get support for each other. We've done research on understanding how refugee communities are accessing hospital care, how they can cover the extra cost of hospital care in Lebanon, which can be a bit, huge on them, even if it's a few $100s or a couple of $100s. And we've established, this understanding that they're just using an informal adaptive mechanism, that's how we call it, by using the WhatsApp. So they create their own WhatsApp group, including kin, family-based network, village-based, groups, whatever. And then they connect with someone from their kin or village or origin who's actually living abroad, and they try to ask for money to support this individual. This is usually happening across a lot of the diaspora and migrant communities, but we see it happening for the healthcare, in the healthcare system a lot at the moment in Lebanon. So they take actually pictures of the diagnosis, they take pictures of any medical report, they send it to someone in Sweden or Germany who made it there better off. He sends a couple of $100s through the OMT or Western Union. They help them in this. It's all happening in many efficient way. And guess what? It's happening beyond all those formal responses that we're talking about. And I think this is quite interesting that usually is not, taken, or it's not taken into consideration within the formal responses. And we need to highlight those informal adaptive mechanisms as ways of complementing the formal, not necessarily competing with it. We need to look at those informal adaptive mechanisms as ways of working through with the formal institution, not necessarily competing with it. I want to stress on this because, as a matter of fact, I see the interest more and more in the formal responses that come from Northern American or European, research hubs and research organizations. I have to say that we need to get together to understand how the communities can have agency, can adapt, and can create their own responses and their own mechanisms, including the use and utilization of these cheap and affordable platforms. But I want to say all of these cannot work if we don't go back to the basics. And that's my, perhaps, conclusion. I think the basics are a must. As much as we want to celebrate technology and innovation, if we don't provide the basic protection for refugees, going back to the values to the entitlements that those refugees need to have in terms of the legal protection, in terms of the social protection, in terms of other forms of protection, all our work is kind of a luxurious exercise. Whether we create the best, virtual reality, whether we create the best way of connecting refugees through these digital platforms, whether we create the best cloud-like system to connect refugees with their, with people who can provide services in the more developed world, it cannot work if we don't provide the basic protection for the refugees. And basic protection starts with legal protection, where refugees need to be actually protected against any harassment. They need to be legally recognized as refugees. They need to be provided with the legal papers and documents to go around and move around. I see this the most prerequisite for any other innovation to succeed. And when we ask refugees, with all of this talk about them and all these, interest in intervening with them and regulating their lives and building apps to help them and building, a lot of design, new approaches to help them, you know what the answer is? Leave us alone. We can manage. We have the agency to actually get along with our lives as long as we're legally protected. Thank you very much.
Thank you, Dr. Nasser, and this brings lots of memories back. I remember when the Syrian refugees started crossing the border to Jordan and Lebanon, the typical UNHCR approach of coordination and clusters and what have you, started talking about standards. And when talking to refugees, they said, we're just visiting our family members because we are extended tribes across geographic borders that we had absolutely no hand in drawing on a map. So that tribal community agency that sometimes is not factored into our standard approach to responding to a crisis is another thing that we need to bear in mind. And I appreciate the fact that you stressed on innovation being inspired by the desire to survive, so that whether you have a hub or not, people are innovative by nature because of their desire to survive. So very much appreciated. Dr. Enrique Steiger, now to you as a founder of the Swiss Cross Foundation, I'm sure you have some insights to share with us around innovation in humanitarian response.
Thank you very much. Let me go to my presentation first. First of all, thank you very much for the invitation and to be among like-minded people. It's really satisfying to hear that actually everybody has realized where the problems are located and everybody tries to find a solution from his point of view of expertise and his point of view of experience. I represent one of those few dinosaurs who has spent the last 25 years in over 23 major conflicts which have afflicted this world. First as a trauma surgeon, then more and more into my second specialty as a plastic reconstructive surgeon. And the reason why I founded my organization came actually out of a pure frustration over my experience over the last 25 years, because I saw ourselves repeating over and over the same mistakes and seeing over and over the same problems all over the world. You have to imagine 25 years ago I was just called by the ICRC, or I worked also once for MSF, and I was shuttled into the eye of the storm and parachuted there and take care of the problem, save as many lives and limbs as you can, and then come back safely home. This was the old times where doctors, physicians, hospitals, and the Red Cross was still respected. In the last 15 to 20 years, when the borders between armed groups and civilian population more and more get blurry, it got more and more difficult. And as you see, and most major organizations have started their own campaign, healthcare came more and more under attack. So what my last speaker said actually quite rightly, everything is based on safety and security. You cannot run a refugee camp, you cannot run a healthcare system if it's not safe here. So we founded this organization about 8 years ago to try to find ways to reverse and counter this escalating trend, and try to find ways and new means how we can provide safe and high quality access to people in armed conflict, to the ones in need. So one of the projects we addressed is under the working title Global Medical Corps. It's a vision and an idea which we try to actually realize here in this region as a startup in this region. What is actually the Global Medical Corps? What is the idea behind? First of all, when I worked in these countries, it was like, yes, we white knights came from the Western world with all our experience, and we are the great doctors, and the local people in Africa or in the Middle East were more or less like decorative people. They were actually window dressing around us. We took care of the patients, we solved the problems, and then we left. And we took all our nice tools and our equipment and our knowledge with us and left them behind to deal with what was left over. So they had to take care of our patients we operated, and they had to take care of what we left behind. But there was never actually really a community of healthcare providers who took care, even after we were long ago, to see what actually was the follow-up, what we did. So what we tried to create with this initiative is actually, we start with specialists, but we want to actually bring specialists in the region and frontline practitioners, where I look myself as a frontline practitioner, together to share the experience of renowned experts all over the world in this field of specializations. And I start with my field, of course, of orthopedic plastic maxillofacial surgeon, but it will not stop there, and to bring this knowledge together with the knowledge which is already existing in the region. Because what Dr. Khoury rightfully said, what's lacking in many ways is a certain quality and a certain level of medical treatment. And the focus should not be on the white knights coming from Japan and Canada and UK. It should be we should be focused on the local healthcare providers. How can we enhance the capabilities? How can we improve their outcome? And so we actually, if we do this right, we can create a pool of volunteers and people, a band of brothers, which you can use also for future conflicts in the region, who speak the language, who understand the culture, and will be part of a greater community. And we already started doing this about 5 years ago together with the Children's Hospital in Zurich, which is a major burn center in Switzerland. We started to create a burn center in Afghanistan, Kabul, in a very difficult environment. And it's actually the only burn center there in a radius of about 1,000 miles who really deserves the name to be a burn center. And it works by support from doctors coming from our hospital, working together with them, giving them the knowledge, supporting them with minimal means to treat these thousands of patients they have to deal with burn children every year. The same thing started with ICRC, which started a small project in Tripoli, similar bit to the MSF project in Amman, where they have this WTTC center in Tripoli, where we started to do some reconstructive surgery on a very high level for the patients we get from Syria, Iraq, and Yemen. And you see, the idea is actually a multidisciplinary approach. So we are not capable, this is actually out of frustration, because we are not able to work in Syria itself anymore. Either we go rogue, like MSF can go rogue, but then you risk the life and security of your patients you treat there, and you risk the life of your staff and the safety of your well-being of your staff. Or you retreat to the border, and in a more or less safe environment, you can start dealing with this problem, which actually are the fallout of poor treatment in the field, sometimes, or insufficient treatment in the field. So we started doing orthopedic plastic maxillofacial surgery as a highly complex surgery, which actually in the military terms would be called level 3, level 4 treatment. We started for the first time actually in the history of the humanitarian emergency effort. We started to do this there, and we started to include training programs for nursing, rehab, psychological support, infection control, etc. So the idea is train local capacities, train local doctors, hand-on teaching, so that in a few years, when these specialists come from New York, from London, from Paris, from Switzerland, they work together, they work on a basic, sophisticated level, getting excellent results, and working together and improve the quality. But it's not only a giving. I'm not talking like a colonialist, imperialistic doctor coming from this. It's always a giving and take. I learned so much from my Afghan colleagues, how to treat something very simple. I learned so much from my Lebanese and Syrian colleagues. So it's a giving and take. But not only that, we actually want to support also, include frontline practitioners. Bring them here, for example, to Lebanon. Show them if you don't treat this burned hand properly, it's going to turn out in a disaster. Because reconstructive surgery is the most, every specialist here knows, is the most expensive part of treatment. So if we can avoid these disasters, and we can avoid disability by good frontline first aid treatment, then we save a lot of human resources, we save a lot of money. So these people in Afghanistan on very simple conditions should already know at least the basics of it. The idea goes further. We don't want, as it is a very expensive center, we would like actually to collaborate with other partners. We would like to collaborate with the AUB, with MSF, with other stakeholders in the region, and take care of a bigger region, like the wars, the conflicts in Libya, Sudan, Yemen, Syria, Iraq, and other places. We want to create here a regional center, medical center of excellency for conflict medicine, introducing new technologies. I know, I heard, innovation is not only about technology, but believe me, everywhere I've worked in the war, we could not work if we didn't have at least water, if we didn't have at least electricity. Even if it went off every hour, it turns off, and we wait a few minutes till it comes back. Well, you had electricity for the last 25 years. So are there ways to improve it? And I was really surprised how many innovative approaches already are there. But are there ways to introduce new technology that somebody, a specialist from London, can show on an iPad or on a phone where to cut, where to do the cut, on what structure you have to pay attention? Is the bandwidth good enough? Is there a safe way to exchange these things? And this is one part we could introduce with this project here. The other one is we became now for 6 months proud partner of AUB, and we try to combine this training, not only treatment, training center with research, to understand what actually affects a war, the bacteria who change in the ground, the social, psychology, and the physical constraints and things which affect the population at war. We still don't understand that. So we try actually to convert this experience into an expertise, to systemize it, and to retain knowledge within institution. Because until now, I can promise you, and MSF will probably confirm it, we have a lot of great experts in the field. They work for 1 month, 2 months, a year, 2 years, but then one day they disappear, they leave, and their knowledge is gone, their expertise is gone, nobody retains his experience, and the next one starts all over again. So we have also to verify the outcome of our treatment. We do so many surgeries and so many things, and we don't know actually if it works. When I was in Liberia, we had 300 patients every day in an urban warfare. And we operated 18 hours non-stop, but I never had the chance to check my patients afterwards. I never had the chance to see them 6 months or a year later. And that's the reason why we should think about new communication tools. How do we communicate with our patients, with the hospital, with our healthcare providers in the fields? Is this too sophisticated gadget? No, I can tell you, everywhere I go in Afghanistan, in the field, there is somebody working with an ox, working the field, but all of a sudden you hear di-di-di-di, and then she picks up the phone and she looks at the phone and she talks with her husband. It's available. This technology is worldwide available. So is there a way to exchange information, to get an information about the wounds, the treatments, maybe the security and safety, without getting my information providers arrested or killed? How do we do that? Can we exchange this information? So I think it's very important that we focus on a future where we stay in touch with our patients and we create a community. So the idea and the bigger vision is we build here a humanitarian hub in the Middle East. In the region, we want to focus on this region, on the local capacity here, so to help them to take care of their own problem. It's a regional problem, and it has to be addressed regionally. And it's not, the solution is not in America and in London, the solution is here. We have to find it here. So once we start a treatment center, we can train them, we can teach them,
We can do research with them because we get the information very nearby. We are very close to the conflict regions. And when we start with the Reconstructive Surgery Center, in about a year or two, we expand it to internal medicine, infection, pediatrician, gynecology, obstetrics. We could create here a kind of humanitarian university and training center for other organizations to come here, for people who want to work in this field, to give them a certificate to see if they're really capable of being deployed into a mission like this morning was presented by the United Nations. Yes, I think we cannot just let every good doer go out into the field and do whatever he wants. We need a kind of, to introduce some system. So the rationale is actually, there is a need for trained medical professionals. A trained quality, the quality has to improve by the local medical providers. And the solution is in strengthening these local medical capacities. People here we have to strengthen. And this is sustainable. We should not be dependent from NGOs and other organizations. And once at the big NATO meeting I said, actually, my goal is to make us, ICRC, MSF, obsolete. You don't need us anymore because you can handle the problem yourself. But this has to be done through basic research. It has to be systemized. So the objective are, let's improve the quality of our medical staff. Let's improve the quality of the basic healthcare. If we have these human resources, they're very valuable. They speak the language, they speak Arabic, they speak Farsi, they speak all these languages. We can deploy them if they're interested in the same area where they're working, because they know the culture, they know they're much safer than a guy from London or from Paris. And if you're building a humanitarian healthcare community, we can exchange with each other. We stay connected with each other. If you have a question, there's not a week goes by, I don't get a WhatsApp or an email with a request from somebody in Central Africa and Afghanistan. Enrique, how would you solve that problem? Can you give me an advice? We can do that. Everything, the technology is here. So building around quality, a good HR, scientific research and education, we can improve the quality and treatment of our patient, which is in the focus and the center of our attention. Thank you very much.
Thank you. Thank you, Dr. Enrique. Before I open the floor for Q&A, I just want to ask all of you, you all talked, as panelists, you all talked about how much learning can happen or is happening and innovation is happening at the very local level. Why don't we hear about it in London? Like every time I go to a conference in the global north, we talk about how to improve the lives of those poor people in the global south. How do we collect, how do we cultivate the knowledge, the culturally adaptable and tailored knowledge, and make sure it's recognized as a knowledge worth studying in universities? Where are we getting this wrong?
I have a very simplistic view about that. I think the problem is that in London, New York, and in all those places, people are talking about a problem they're actually not really personally familiar with. Most of the areas we are now discussing is there is no access for most of the normal. I mean, my small foundation moves in the tribal area of Afghanistan, where the U.S. Army said to me, if they don't even go there with their Navy SEALs, they just are with their B-52 bombers 30,000 feet above it. So many conflicts now happen under the exclusion of the international community. Nobody is there physically anymore. And these few individuals who are there physically, like MSF doctors and some other crazy individuals who really move around there, there are no eyewitnesses anymore. The only thing we see is what we get over WhatsApp and these kind of things. But do we know if this information is true? Because the first victim of war is the truth. We all know that.
So we have been working on a project for the last 6 months, which is looking at how we can connect local MSF teams around particular problems and challenges and solutions. And we actually sent a designer, researcher, and a data guy to the field to talk to field teams. And one of their major insights was, if you want to increase exponentially the impact of innovation in MSF today, you better communicate the innovation that's already happening at field level, rather than investing in completely new stuff. And I thought that was really, really, really interesting, because that's not how we generally talk about it.
I think we're going to the wrong conferences. Answering your question, I think I think there are three defects in the way we do the formal response to crises. One is that formal defects that are not actually bringing those local, informal, community-based, interventions or responses. One is that we work through timelines that are so limited and bound. So we actually work through 1 year, 2 years at max. If we want to deliver our project, we want to fulfill the funding cycle and so on and so forth. So that does not allow, my second point, to the time that is needed to work with local communities, with local actors, with community groups in order to actually listen to them, understand them, and work with what they actually have been doing themselves in terms of the response or adapting to the crisis. So I don't think the time and the money and the resources and working through log frames and outputs does not actually allow for what could be the luxury of working with local communities. But also, we don't see refugees or their poor host communities as agents. Most of the time, we see them as recipients of aid, as subjects of aid, subjects of research. This is the terminology we use: human subjects, subjects of research, beneficiaries, not as agents. And I think this needs to shift, I guess, in terms of the thinking as well. But these three perhaps come together.
So maybe some of those paradigm shifts really need to be factored into how we respond to humanitarian situations, perceiving beneficiaries as such, to treating them as end users and clients, the whole shift of donors from donating money within a time frame to investing in improving life quality for end users. All those paradigm shifts will require some revolutionary, movement of some sort, because unfortunately, as we are encouraged to innovate and take risks and disrupt, we have to submit a report by the 31st of December, hitting all the KPIs and reporting on head count. That's how we measure impact, and that's quite concerning. I'll open the floor to the audience if there are any particular questions that you'd like to raise. Please.
Thank you very much. My question is about collaboration. There was a lot of conversation of collaboration between local groups, governments, but I wanted to know if any of you have experienced any innovation in the collaboration between different agencies intervening in humanitarian contexts, like among basically yourselves, and what are the challenges to these collaborations and ideas for addressing these challenges? Thank you.
Maybe take another question and then we'll open the floor for the panelists to respond. There's one in the back.
Actually, what we heard was very interesting, and a lot of work is being done in order to stop any crisis. However, the main challenge, which I believe is the gap that exists between the governmental and the academic institutions. So the link is missing. As I see in Lebanon, we don't lack capacities, neither academic nor NGOs nor local communities. However, the governmental decision is what is missing, and the governmental capabilities of doing such humanitarian acts is what is missing. So how can the Global Health Institute at AUB, is addressing this issue, and international NGOs? What is the link between your work and local governmental institutions? Thank you.
In our work in the field, we find there's a big challenge. There's a lot of refugees or vulnerable people don't know about the programs provided by international and national NGOs. And we're trying to find some innovations for the refugees to make the registration in the programs more easy. And it's the registration by WhatsApp. We find in Urda by our work. But we think we must work more in innovations to make small capacity building for the refugees themselves, to know about the programs, to know about how to find or how to early detection the problems. For example, we find a lot of small children with congenital malformations. The parents didn't know about the problem, and they came to the doctor very late. For example, DDH, scoliosis, undescended testis, hypospadias. It's small things. If we can treat very early and the refugee know about this challenge and this problem, they can come very early to the medical center and talk about the problem. I think the most work with the congenital malformation now is to make small capacity building for the vulnerable people and for the refugees themselves to know about these problems. Have you any innovation to work for the refugees to build the capacity for the vulnerable people, not for our organizations? Thank you.
I would like to respond to the first one because it's the most provocative one. Me as a frontline practitioner would say the collaboration among big organizations is really poor. It's really almost non-existent. And why? And I explain it from my point of view. I don't explain it, I cannot represent any organization. Just the reason why we founded a non-organization is not, the goal should not be that we start all over. With every new problem, we start a new organization. Actually, we should reinforce the old organization. There is the UN. The UN is a fantastic organization, but it's as good as its member states. And that's it. That's the limit. And one of the most important organizations is the ICRC, which is actually the holder of the International Humanitarian, the Geneva Convention. It's a very powerful organization. We have to support this. And MSF, who is in a specific field. So this has to improve. And the future is not by the good doers and by donation. And the solution is an economy. It's an economy. It's stupid and simple. And the more the funds get reduced, now we see what's happening in the United States and things like this, the harder probably will be the fight for these limited funds available. So I don't see in the near future an improvement of that problem, but I think the reason why we sit together here and what AUB's initiative is actually to address this problem.
Thanks. I'm going to respond to the same one, sorry for not diversifying. There's a lot of talk at the moment about this thing called networked humanitarianism, which is essentially viewing lots of different actors in a humanitarian crisis as nodes in a network. So rather than the big INGO being the castle in the middle and everybody else being around it, it just being another node that offers value that's different and needs to be networked with all the other bits. MSF and I think most big NGOs are really bad at this at the moment. And I think there's probably many reasons, but I think a couple of reasons are the day-to-day reality means that time is short, and good partnerships and good networks, they take effort. And I don't agree this is necessarily it doesn't make us efficient. I think there's a huge opportunity cost not investing in these things, but they do take effort and resource. And the other thing I think is understanding the mutual value and the different motivations that exist within a network and within partnerships, and different organizations coming from different cultures not able to kind of quite make that leap and understand where others are coming from.
Yeah, so maybe I'll just address the second question. So in this Westphalian world, we've made the assumption that the sovereignty of states means that they're all equally capable and interested in looking after their citizens. But the hard reality is most people live in countries that do not have governments which have legitimacy, authority, capacity, or capability. And that is the brutal reality. So your discussion about how do you work within the healthcare sector, many of these countries, I mean, the health minister, if he or she exists in the first place, is cycling every 2 or 3 years, or they have virtually no power and authority. And a lot of the solutions we often work with are ones which have to stay below the radar with governments. So this is about civil society and building up the solutions and sustainability within civil society. But on the flip side, of course, we have the rise of self-interest in high-income countries now. So all the funding for directly allocations to health now follows strategic national interests, and that can be in development, in counter-terrorism, counter-proliferation, you want to name it. So things have got very, very difficult because of these two things sandwiching. So I agree. I think the world, the next 5 to 10 years, is going to become far more challenging. And the idea of that, I remember the 80s, the utopian, this is we're all in it together, brothers in arms. As far as I can see, it's vanished. And it isn't coming back anytime soon.
Not the most positive note to end up the discussion with.
Look, I'm a real politic, so you work with the reality on the ground. I mean, I'm great for principles, and I love, principles, and but that is just the reality. And if you want to make the world better, and you actually want to deliver something for it, you have to work in the real world, not in some, I'm going to say this, virtual fantasy.
Yeah, no, I absolutely agree with you. And, as we see the tendency to building walls these days seem to be much higher than, the tendency to building bridges. I think resource mobilization and finding useful or practical ways to allow knowledge and learning to make it to the most vulnerable is going to continue to be more critical than ever before. So that whole world of dependence on institutional donors to keep, programs up and running will need to be revisited. The world is definitely changing, and innovation, technology included, can be used to revolutionize access to relevant learning and knowledge and professionalization of local actors who can fill in the vacuums and fill in the gaps by the support or with the support of the likes of you and others. Very interesting discussion. I'm sure that there are more questions than answers in the minds of those who listen to us, and I'm sure that the debate will continue for the coming 2 days. But until now, we say thank you to our panelists here. Thank you for your questions and engagement,